Thank you all so much for being here. Again, my name is Kirsten, and I'm going to be facilitating our webinar today on behalf of CHAMPS. This webinar is part of the Wednesday webinar series that we do in collaboration with the Mississippi State Department of Health. And today is specifically focused on how hospitals have used the baby-friendly audit tools to improve their practices and just get closer to their baby-friendly goals. Again, my name is Kirsten. I am a coach for several of the hospitals that we work with in Mississippi and a project manager for CHEER. Presenting today, we will have from Merit Health Madison, Carmen Alexander, who is a PhD prepared nurse and Director of Women's Services in the Med-Surg unit there at Merit Health Madison. She has worked for the Community Health Systems, which is like the parent company for Merit Health for 24 years, so a lot of experience there, and has been at Madison since September of last year. So we're excited to have Carmen present today. From Merit Health Women's Hospital, we've got Renee Simpson, who has been a newborn nurse with Merit Health Women's for 20 years now, and about 4 years ago became an IBCLC. And about that time at Merit Health Women's, they started their lactation center, which has allowed them to see women on an outpatient basis to provide lactation services. And Renee is also the baby-friendly lead at their hospital. So we'll hear great things from Renee today. At Anderson Regional Medical Center, we have Lindsay Robertson, who is a nurse in their labor and delivery unit and a CLC, and she's also the lead for their baby-friendly project at their hospital. And she's been at Anderson for 4 years. So we've got a lot of experience on the line, and we're going to have a great webinar for you today. Really quickly is a little bit of housekeeping. So if you want to mute your line, you can push *6, and then if you want to unmute your line, you can press #6. If you put us on hold, then we'll hear your hold music like you're talking to us, so don't put us on hold. I'm going to encourage you to use that chat box throughout the presentation. If you have questions that come up, just put them in there right away. We'll take questions at the end, but if you want to type in all of your questions into the chat as the webinar progresses, then you won't forget them, and they'll be there. They'll be ready to be asked when we get to the end. And then really quickly, we've got some upcoming CHAMPS clinical skills trainings. You can see where all of those are happening on the slide here. So coming up at Gilmore Memorial Hospital, Singing River, and Bolivar County are happening in June, as well as a training at the Mississippi Baptist Medical Center in July. And all of those have some empty spots left in them. So if you are, if your hospital is near any of those hospitals and you would like to send staff to some of those trainings, you can just go on our website, cheerequity.org/trainings. That link to that website is right there in the slide. And you can sign up your staff if you are a CHAMPS hospital to go to trainings at nearby hospitals. The two trainings that are happening in August at Rush and Merritt River are, right now they're still closed to everybody else while those hospitals are still enrolling their own staff, but those should open up and have a few extra spots if you're interested in sending your staff to those trainings as well. Those are really fun trainings. If you have ever had a training with Kathy Struthers, you'll know they're really interactive and just a great learning experience for your staff. And then finally, we've got a Train the Trainer event. So if you have staff who you would like to have teach that 4-hour clinical competency class to the rest of your staff, they can go to this Train the Trainer with Kathy and learn how to teach that material to your staff. And we'll also provide you with the PowerPoint and handouts and things like that that go along to support that training. So really consider sending staff to that Train the Trainer event. It's really especially designed for if you have ID CLCs or CLCs at your hospital. They would make great trainers for the rest of your staff. But really, if you have staff who are really good at training and they're pretty competent at breastfeeding, they don't have to be a CLC or an ID CLC. If they have attended any of the 4-hour, if they do need to have attended a 4-hour clinical competency training with Kathy before they can do the Train the Trainer. But that is an exciting opportunity. So again, you can go to that link that's there on the slide, that's shareequity.org/trainings, and you can register staff if you've got staff that you would like to send to that. All right, and then upcoming Wednesday webinars, here we usually talk about when the next one is going to be, but we are taking a little break for summer. So we won't have another Wednesday webinar in July or August, but we will be back in September, and we would love to feature any ideas that you have. So if you have specific things that you think would be really nice to learn about in a Wednesday webinar, send us your ideas and we can start putting some of those webinars together. All right, and then, excuse me, on to the exciting part of the webinar today, really talking about these audit tools. So before I turn this presentation over to our hospital presenters, I'm going to take a couple of minutes and just provide some basic information about the audit tools and their context within the baby-friendly process. So, as you all know, baby-friendly helps hospitals walk through the process of baby-friendly in a kind of stepwise fashion here. You go through your 4 phases. So discovery, your hospital has access to the Baby-Friendly USA portal, which is, it's kind of like a little secret garden of materials and things that will help you become baby-friendly. You can only access that portal with an email and password. So 3 people from your hospital will have access to this portal, which you gain login access to at discovery. You then move into development. After you've learned about what baby-friendly is, you move into the development phase and you start making your plans. So plans around staff training, how you're going to educate your patients, how you're going to collect your data. You write your infant feeding policy in development, at which point you get to move into dissemination. And obviously I'm distilling a lot of this down just for the sake of time. I think most of you know this stuff and have heard it a million times, so I don't want to get too into the weeds here. When you move into dissemination, this is where you're starting to implement all of your changes. And this is where your portal opens up access to all of these audit tools that we're talking about today. So if you haven't gotten to dissemination phase yet, these audit tools you have not seen these audit tools yet. So just be patient, they're coming and they're really, really helpful. So get to dissemination and you'll have access to those. So in dissemination, while you're making all your changes, you're able to use these audit tools to really determine how well your hospital is adopting these practices and making these changes. And then once you get to designation, you continue to use these audit tools as you are preparing for your mock assessment with CHAMPS, as you are getting ready for your readiness assessment interview with Baby Friendly, and then as Baby Friendly comes to designate you, you're also just continuously using these audit tools to make sure that you're meeting that 80% threshold. And these are also the audit tools that Baby Friendly uses when they walk through your doors to do their assessment. So it's really an open book test in a lot of ways. On this slide, I'm not going to, it's just a list of all of the audit tools that Baby Friendly provides in the dissemination phase. Baby Friendly provides a tool to audit every step of the 10 steps to successful breastfeeding, plus the International Code of Marketing of Breast Milk Substitutes. And you'll see on the slide here that the tools are bundled up so that some tools audit more than one of the 10 steps. So you don't necessarily have 10 tools for the 10 steps. You actually have 7 tools for the 10 steps and the code. And then just because I'm not going to spend a bunch of time getting into the weeds and all of these, but I did just want to point out the postpartum audits in particular tend to be the place where we have the most confusion. So I'm just going to point them out purposefully here. So the postpartum patient interview tools are listed on this slide in black. And most hospitals bundle these 3 tools together when they interview postpartum patients. So they ask all of the questions of these 3 tools in one interview. And it feels sometimes like a very long interview, but that's just an important piece to point out. And I just wanted to just make sure, just go back and double check and make sure you've got all 3 of those audit tools in your interview bundle when you're doing your postpartum interviews. Great, okay. So let's see. I know that our presenters today are going to talk a lot about the purpose of the audit tools, but just to kind of give a little introduction there, I wanted to talk about this a little bit more. So the purpose of the audit tools really is to drive change in your facility. Doing the audit tools for the sake of just going through the motions really doesn't have a purpose. So the real purpose of these audit tools lies in creating change from what you learn as a result of the audit. And change is really hard, and it feels like a lot of extra work at times, which can be especially difficult when you've got staff who are already really busy. But if we do it right, we have to just remember that that change leads to a higher quality experience for our patients and for the staff as well. So that is why these audit tools and making these changes are so important. And then just, I always think of change kind of happening both at 2 different levels. So at the level of the head and the level of the heart. So thinking about, like, a lot of your staff will be swayed by the numbers that they see in the audit. And that will be, like, that'll really drive them. That'll get them out of bed in the morning. And others will be swayed more by the stories behind the numbers. And so really thinking about how you can present to staff with both a head and a heart, the numbers and the stories behind your audit tools to really can create that reason for creating change. So at this point, I'm going to turn it over to Carmen Alexander at Merit Madison so that we can hear a little bit more from her about Merit Madison's experience with using the baby-friendly audit tools. And I will let Paige provide that ball. Let's see, Carmen, or actually I can do it really quick, Paige. All right, so Carmen, the ball is coming to you, and I will let you take it from here.
Okay, thank you. Again, my name is Carmen Alexander, and I work here at Merit Health Madison, and we're located just off of I-55 in Canton, Mississippi. And the construction of our hospital, it actually began in 2009, and it was a new construction. And so after much anticipation, the doors of our modern facility opened in May of 2011. And our hospital is a full-service medical center dedicated to providing excellent care for our patients, as well as a safe work environment for all of our employees. And so here I have a few pictures of my staff, and they're an amazing group of people working really hard every day to make sure we take care of all of our moms and babies. Okay, baby-friendly, it isn't a new policy or a new protocol. It's a shift in how we practice. It is essentially a culture change, and this change affects everyone. That includes healthcare workers, patients, family members, and of course the driving force behind this initiative, babies. D3 is the ongoing phase of imparting baby-friendly information to the facility staff as well as to patients. The dissemination phase, as it implies, it involves the collection, analysis, and sharing of the information that you gather from your audit tools. Upon entering D3, we would suggest that you immediately start collecting your data and doing your audits on a consistent basis. So today, for us, I would like to focus on 4 areas that we felt were very important in D3 or the dissemination phase, and those were planning, consistency, follow-up, and sharing. And then I'll just kind of highlight a little bit of information on each of those 4 bullet points. In terms of planning, a few questions you should ask in regards to the tool itself. Does the tool provide it? Does it work for us? Do we need to include more or less information? And then also, how can you structure the tool to be more meaningful for you? And then next, set a target and stick to it. Remember to allot time for those unexpected things. And of course, these things, they will occur. And to me, women's services is much like an emergency room. You never know what to expect, so always be prepared. And then, what is the best place to conduct the audits? This is a question you should ask yourself, because whenever you're meeting with the patients as well as your staff, you're trying to get as much information as you can from them. And so whenever you're deciding that, whether that be a small conference room, in your office, wherever that is, be sure to prepare for the best place for those audits. Also, how long you want for each session, and is there any additional information that will be beneficial for you to collect at that time when you're talking to the employee? And these are just some of the important questions that we thought were important for making the most of your time together. Again, that's with patients as well as with staff members. And then consistency. To be successful with your audits, be consistent. Of course, you want to tailor your conversation to meet the needs of the individual. However, be consistent, and this helps to avoid leaving out important information or even forgetting to ask a question. And another thought is we can't be baby-friendly when it's ideal. It must be done at all times. And I can remember in the beginning phases, we would give each other what we call free passes. We would say things like, oh, it's busy today, so let's just not do that. Or that was a really complicated delivery. And then other excuses such as she, referring to the mother, is not really into what we're talking about. And so sometimes things like that can be a deterrent for us when we're trying to get through baby-friendly. But remember, like I said, it's not a new policy or protocol. It is a change in culture. And then lastly, follow up. So now that you've gathered all that information, what next? Share what you've collected and found during your unit staff meetings and during individual meetings. And this should be done with patients and family members as well. Some examples are to ask open-ended questions, ask for return demonstrations, and this allows you to assess for readiness, learning readiness, and also for retention of the information. After all, what good is the information if we don't do anything to grow the body of knowledge? And then every month for us, we had just one priority or focus area, and this allowed us to take things one step at a time. For example, one month we just chose to focus on formula preparation. And so once the staff was able to go over the information over and over again, it kind of became second nature, and they really began to understand what the information meant and how they could disseminate that information to patients and family members. In terms of audits, the staff members, they knew the questions that we were going to ask them and what was expected of them. And so each month they were actually able to provide new ideas and bring those new ideas to the table. And I will stress right here, creating an environment of inclusion is so critical during these times. You want to create an environment where people feel empowered to speak up and to share their ideas. So this is not a time for belittling staff or criticizing them. This is a time for them to feel empowered. Also, the second element, areas of improvement were celebrated. And so anytime we conquered a task, we celebrated, even if it was something as small as a high five. It makes a difference when everyone can see that we're headed in the right direction. And then another thing that we did, we actually have what's called the Baby Friendly Nurse of the Month, and we just post that, and that way everybody throughout the unit can see that this nurse went above and beyond in helping us with our accomplishments. And then lastly, any areas of concern, be sure that you address those on an ongoing basis. For example, whenever we had staff or patients that just didn't seem engaged, we just took extra time with those individuals to make sure that they understood the why. Sometimes people just need to know why. Why is this important, or why does it have to be done that way? And usually once you get the why and you explained it to them, they are more compliant after that. And then the key points and takeaway lessons for us is learn what works best for your facility. And then most important for us is just to know your staff. Build a rapport with them so that they will be willing and open to share information. And then number 3 on the bullet points is once you get that information, share what you've learned. Kirsten kind of alluded to that earlier, so be sure that this is an ongoing process, a growing process. And then lastly, be sure that you're creative and innovative throughout this process. And so some of the goals that we felt were very important are to provide evidence-based information to both our patients and our staff, and again, showing them reasons why we support this initiative and ultimately the impact it will have on the community at large. Another goal was to provide a safe environment for our clients and to assist in the optimal nutritional health of our most prized possessions, and those are our babies. And remember, when these things are first and foremost, we can all become baby-friendly. And like Kirsten said earlier, we'll take questions at the end, so if you can just put those into the chat box, and I will turn that over to Renee, or I'll get Kirsten to turn that over to Renee. And thank you for your time.
Awesome. Thank you so much, Carmen. That was great. And I will let actually Paige turn it over to Renee, because Paige, I don't think that I can manipulate this once I am not the presenter.
Yeah, I'm just having a little trouble grabbing it and scrolling down. Just a second. There you go. All right.
Got it. It looks like Renee has the phone out.
I do.
Awesome. I will let you take it away, Renee.
Okay, thank you. Can everyone hear me okay, Kirsten? Sound good?
Yes. Yep, it sounds great.
Okay, thank you. Thank you, Carmen. I'm Renee Simpson. I am the lactation coordinator for Merit Health Women's Hospital in Flowood, Mississippi. And Carmen's hospital is part of our sister network. We are composed of 8 hospitals right now under the Community Health System umbrella, and we're known as the Merit Health System. We were recently, by chance, honored to be one of the champions of the week for moving along the baby-friendly pathway together. We had a call this morning. We have monthly calls, and we kind of go over where everybody is on the pathway, We talk about audit numbers for everyone, and just kind of give each other some support and encouragement along the way, because the nice part of having it as a system is everybody's in a different spot. So we call each other, email each other, and really support each other, and that has been great for us. We deliver approximately 1,100 babies each year. We do not have a prenatal clinic. Our physicians are not employed by the hospital. We're a level 3 NICU with L&D, newborn, postpartum med-surg nurses, and then same-day surgery unit. We are not mother-baby, and that kind of in itself has led to, so we've had to be creative in how we do our education and with our moms and our staff, since we are all separate units. Our baby-friendly journey began back in 2015 when it became a CHAMPS hospital. We entered into discovery in 2016, development in May of 2016, dissemination, where we began our audits, was in January of 2017, and then we entered into designation September 2017. So we've already had our readiness assessment interview with Baby Friendly. That was in January. We were hoping to have an on-site visit with them a little sooner, but they, I think they have a lot of hospitals that they're surveying right now. So our on-site survey will not be until this fall. But by this fall, I mean it's going to be early fall. So we're probably about 8 weeks away. Getting a little antsy. We're trying to make sure everything is like we want it. Our challenges were, like I said, we do not have a prenatal clinic. So for these moms to get the education, we've had to kind of rely on our breastfeeding education classes. Not everyone takes breastfeeding education classes. Our childbirth education classes. So we're working together. River Oaks Hospital and our hospital combine our education for our moms, and we're trying to work together on just getting them the information on Baby Friendly. I've also made packets for our OB clinics and included Baby Friendly information in that. There's a letter from me that I've included in there, and that just kind of explains, those packets go to the mom. What we discovered with those packets going out to the moms, getting some education to them, was it was going out a little too early. When the moms pre-registered for with their OBs in the clinic, they were giving those packets out like day one of seeing the mamas. So the moms that I've had, that I've done dissemination audits on, and I will say, if they're not quite giving me the answers I want, I will say, do you remember receiving a folder with some information in it and a letter from me? And one mom said, oh, you know, this is baby number 3. I remember getting that, and I threw it on the back seat of the car. So, you know, our challenge in that was, okay, can we give it to the moms a little bit later in their their prenatal education with the kind of trial and error when you try to find out, I say, this is a great idea, and then you execute it, and you have to go back and kind of revamp it. With us, our challenge also was closing our nursery. We don't have a nursery anymore. We try to get the staff to say, we don't have a nursery. We have a holding area in NICU for our babies. So rooming in is still our biggest, I think, challenge right now. Our percentage is going up. We're very excited to be over 60%, heading toward 80 some months. We have a high C-section rate, so recovery with those moms can be long. They're hurting. They want babies to go back, or it's their second or third baby at Women's Hospital, and they think, oh, yeah, I know you have a nursery because I've sent another baby there before. So it's all in re-educating our moms as to how we're doing things right now. rooming in also has been a little bit of a challenge for the night shift. That's when our moms kind of fall apart. And so we have a CLC on the night shift that is a new CLC, and that's really, I'm seeing a big difference in our audits with that. And then our postpartum nurses, like I said, we're not mother-baby. They have med-surg assignments. So they may have a postpartum mother here, and there's a med-surg patient that they're giving blood to. So it's kind of a balance with them in trying to, with time constraints with them in assisting moms. They're heavily relying on newborn nurses and lactation at times. So I've had to kind of adjust the way, you know, if I go down to the unit to help them with a mom that needs help breastfeeding and I see that they really and truly are with another patient, then I'll go back another day. The dissemination audit tools, when we first got into dissemination, they were very overwhelming. I wasn't real sure what to do with those. What I did was I just printed them all out, and I made master copies and put those in a notebook so that I always knew where my master copy was. In the beginning, we were making the copies of those dissemination audit tools, and I had hundreds of pieces of paper. So we kind of went back and said, okay, let's see, number one, who is going to do the audits, and when will we conduct the audits? So on the who, in the beginning, I thought it was a great idea for the managers to do a few so they would see what their staff needed to know and what we were asking the moms. Well, on the staff audit tool, the managers are not going to be your best person, I discovered, because they don't want their staff to look like they don't know, make 100 on their test. So some of those were not real transparent. So I had to go back and say, okay, never mind, we're gonna do this differently. So we've done it a few different ways. I have a few staff members that are really interested in lactation. They really love it. They have been to some of the Train the Trainer classes with CHAMPS. They've been to the CHAMPS classes. And so those few staff members that you pick out that are really going to be your champions are the ones to help you with the audit. And they'll also help you with education with the staff, because when they do the staff audits, if there's something that the staff doesn't understand or doesn't know, then you've got somebody to get in there and get some education done with them too. Our lactation department does a lot of interviews just because we see the moms back on day 2. And we have found that as far as when to do the audits, day 1 of delivery is not the day to do it. Sometimes on the section moms, day 2, we're telling them, we're educating them, but they're still not getting everything, so that's not a good day. All of our babies come back day 2 after discharge. They come to the outpatient unit. So when they're in outpatient, we have found that that's really a good time to do some of the audits with them, because at that point they've been home. When we talk about hand expression and we give them handouts on hand expression, they've been at home. Hand expression suddenly is making sense to them. So we're getting some, oh yes, I do remember you talking to me about that. So it's kind of trial and error with your audits. We do 100% audit. We audit every day, every discharge, and I've come up with a lactation educator checklist. I'll be glad to send that to Laura. It's just something that's helped us. That way we go in every day and look at the chart, discharge, and see is everything documented, is skin-to-skin education on there. Did we talk to this mom about pacifier education? So it's just a good little tool, and it doesn't take long to really just kind of go through that every day, so that when the moms do come back on day 2 and we're doing our audit tools, we know, okay, this mom didn't get skin-to-skin because of a medical justification. Let's talk to her about that. So that's helped us a lot. And then I have, at the end of the month, kind of tally everything up, see how many exclusive breastfeeders we have, and that's helped me with my facility data sheet, which you'll have to submit for designation anyway. So those are good, just good little tips on how to get those things going. Whatever your results are on your audit tools, I would suggest giving them to management and administration. I make sure my CEO and my CNO know our results every month, because I think they're going to be backing you up. If there's an area that you have an action plan on, they need to know it, and they need to know, that we need some extra help with nurse managers or whatever with the unit. And then I post the results each month for the staff, and they really enjoy seeing that. And sometimes if the audits are a little bit lower than they were last month, I had a nurse the other day that said, I don't understand, we're working so hard rooming in, or whatever the lower score was. So they do, they look at it, and they pay attention. What we've learned from our audits, from our dissemination audits, the main thing is if you just, every day when you talk to your moms, you're really doing an ongoing audit just by talking to them, and you're going to find out a lot of things from the mothers. One of my mothers the other day said, I go in and I will ask, well, how was your night last night? And one of the moms said, oh, it was great. My sweet little L&D nurse came down to visit with me during the night, and she was telling me she had a baby and it was okay to give the passy. So I gave the passy, and then she said, I look so tired, so she took the baby back somewhere for me. And she said, I'm not sure where the baby went, but the baby went back. So, of course, you have to keep a poker face and say, oh, that's great. And then you go back to the chart and you start doing your investigating and see who the nurse was, and that way you can educate a little bit without the mom knowing that you're actually horrified by that answer. Another thing we found a mother say, I was talking to her and she said, I saw a pacifier in the bed that I knew was not, probably not hers because it wasn't there the day before. And I asked her about it, and she said, well, I'm real confused about the pacifier education. You were telling me yesterday to not use the passy as much for a feeding cue, but the hearing screen lady came in today and told me she needed a pacifier. So I could do some investigation with that. As it turns out, the hearing screen company that we use, part of their guidelines is to use a pacifier with the screen. So we've had to kind of backtrack and do some things with that because this company goes to more than one Merit Health hospital. So hopefully we've got some of that cleared up. And then the other thing is just kind of figure out how you can get these audit notes out to the moms. Staff, we do quizzes. They love potty notes. That was a request from the staff. They said if you'll just put something on the door in the bathroom, we'll see it every day. And that's worked. Even our administrative secretary said she's learned a lot about baby-friendly by just reading potty notes. And then if it's possible, when you have some downtime, you can, and you have a lactation staff, not all hospitals do, you can just assign nurses that are kind of struggling with it to lactation. And then those numbers are going to fluctuate every month, and I try not to get too panicky about it. Just do the action plan and just kind of go from there and say we may be doing the same action plan every month for hand expression, but eventually we're gonna forge through and get a better number next month. In our readiness assessment interview, I will say by having our audit tools, our dissemination audit tools organized, that helped me so much because I had everything tabbed by the month, and they will ask you line by line on the audit tools a percentage. And so if you have it there and you can flip back and forth and you'll have that number ready for them, it makes a huge, huge difference. And it kind of gives you a little confidence with that call. Also, kind of before the readiness assessment call, I got a notebook together and just kind of individually looked at each step of the 10 steps and just kind of made sure that I was doing everything I needed to do. So I had that notebook with all of those audit tools. Like Kirsten was talking about earlier, you'll get the policy audit tool, the staff audit tool. So that's kind of where we are, and I hope I've given you guys some ideas.
Awesome. Thank you so much, Renee. Those were great. I love hearing about all of the little details and the way that you're using those audits. And it's fun to hear how each hospital sort of approaches how they use audits and disseminate that information in different ways. So thank you. Again, if you have questions, just type them in that chat box, and we will get to them at the end. And we will move on to Lindsay, who is at Anderson Regional Medical Center. And so I don't know, Paige, if you can see Lindsay Robertson's name down in the chat or in the participants list. You can hand her the presenter privileges.
That, Lindsay? I just passed it to you. Okay.
Yep. Oh, great. Okay, right. Thank you so much, Lindsay. Take it away.
Hi, my name is Lindsay. I'm from Anderson. I'm a labor and delivery nurse, been here for 4 years, and somehow ended up in this position leading the Baby Friendly Initiative, but it's been a great experience. Let's see. We are a family-owned hospital. We were established in 1928. We have a level 3 NICU. We have 3 separate units, so we have 7 LDR rooms, 3 triage rooms, and 2 operating rooms, and 25 antenatal and postpartum rooms. We are separated L&D, postpartum, and nursery. So like Merit Health was talking about, that sometimes that can be a little tricky, especially as far as education goes and who's responsible for what, because everyone, you know, kind of wants to say that, you know, this is nursery or this is labor and delivery on admissions, but in the end of the day, it's really all 3 units' responsibility and all 3 nurses who are taking care of that staff member. We have 2 IB-CLCs, and we also recently added 2 CLCs, myself and another postpartum nurse. So we were trying to get some people there that would be on different units and not just in the nursery department. Our IB-CLCs, we have our own lactation center, so all our postpartum and outpatients come back to that center. We also do our breastfeeding classes and labor classes in there as well. We average about 1,200 deliveries a year, and we're currently in phase 3, dissemination phase. We entered it last September, so hopefully planning on moving early fall into the summer into D4. We do have 1 affiliated prenatal clinic, which is actually a pretty large, they do about 400 to 500 of our deliveries. So they just became an official affiliated clinic within the last year, so that's been a real big challenge for us because they have been a private practice forever, and now trying to get them on board and having to realize how important they are in this whole process has been a big challenge. The rest of our providers are either affiliated with the hospital down the road, but most of our providers in the town deliver at both hospitals. So both of these hospitals are on the Baby Friendly Initiative, so it's beneficial for the prenatal education to go to all of them. Let's see. Before Baby Friendly, we did not do skin-to-skin with any of our deliveries. All of our babies went back to the nursery immediately after delivery. Moms got to love on them, take a couple of pictures, and then they went on back to the nursery where they started their whole observation bathing process that usually took about 2 to 3 hours of separation with the moms. The majority of our babies went back to the nursery at night. It was just kind of the norm. All of our babies were sent out with a passy in their crib. So when the babies went back to mom after their bath, they had their passy in the crib with their diapers and their bottles of formula. All of our moms were discharged with formula bags and samples, and no prenatal breastfeeding education was provided by the clinics at all. So we had a lot of changes to make, and we've really, really come a long way. So, I'm sorry, click a little first. Okay, so our patient, did I go too far? No, I didn't. Our patient audits and prenatals, the 2 of the nurses from the affiliated prenatal clinic have joined our core team. So we have those 2 nurses as well as the midwife in that clinic. And we really had to get them on board to get them sold on the whole Baby Friendly Initiative in order for them to conduct the prenatal education the way we really needed it to get across to our patients. So we included them on our core team. We actually had our lactation consultants also do like a little mini info session, almost like a mini version of Catholic Brothers, 4 hours, because at the end of the day, those nurses really didn't know much about breastfeeding. So we were giving them all this education, telling them how they needed to teach it to the patients, but at the end of the day, we realized they didn't really even know themselves. So we had to educate them just like we would one of our own staff members here at the hospital for us to be able to get the right information to our patients. So we had them do that training. We also wanted them to take ownership of their prenatal audits. So we assigned them to do 10 audits a month for them. But after a few months of getting it, I realized when I was doing them on patients that came in for outpatients or for NSTs or something like that, and I was just doing on those, and our results were not good at all. Well, the minute we passed them, the results were 100% in most areas, which so I knew they were doing a lot better job of teaching it, but I also think it's a good idea to still do a few of them on your own to make sure the validity and the verification of it, because it's kind of like someone else said earlier that, you know, you want your students to make 100. So you want to make sure that those audits that they're asking them the same way that you would ask them. So I would make sure you have a few people doing, some of your staff from the hospital doing them, as well as let them take ownership of those audits as well. Okay, so for the postpartum audits, what we did is we recruited a couple of core team members to conduct the monthly audits, preferably not a manager when they have their hands full, but probably someone that's on your core team as well. So we have, I have another labor and delivery nurse that's on our core team, and then my co-lead, which is a nursery nurse, she's conducted a few for me, and then a couple of IBCLCs as well. But you really don't want your team that's conducting audits to get too big, because you want to make sure they're consistent and they're being asked the way you know they're supposed to be. They can be, what we do is we do them on either on discharge day, or if I'm missing, we have to have 25 a month based on our delivery. So if I'm missing some, I actually go through the delivery list of that month and I call. And I kind of, at the beginning, I caught myself kind of looking at the list of patients on the floor that day, and I'd be like, oh, that'd be a good one to do an audit on. And so I go in that room, and then I kind of caught myself avoiding the ones that I thought may not be that great, whether they were bottle feeding or I knew they probably didn't stick to breastfeeding, whatever the case was, or I kind of caught myself saying, oh, that baby's in the NICU, I really don't want to go in there and talk to that mom. And then what you realize is you're having biased results, because that's not a true tell of your clientele and the deliveries you've had that month. So what I started doing is I just went to the postpartum unit. I'd say, tell me who's going home today, and I went through those rooms one after another. So when I walked in, I just asked, how did you deliver? You know, and I kind of got the story as I was in there, and that way there was no biases, how they delivered, how they were planning on feeding before, anything like that. I learned all that while I was in the room with the patient. And it allowed me to kind of get truer results of how we're actually doing. Another thing is to, when you're conducting an audit, remember it's what the patient perceived or they remember. So even if I caught myself a couple of times doing audits on patients I had delivered, and I knew I had admitted them and I knew I had told them, but they couldn't recite it back to me. So that told me that I either missed the mark, or you know, we got to do something a little bit different, whether they didn't get it again after delivery, or but you have to remember it's what they perceived and not necessarily what you know you told them. Follow each audit with an audit of the EMR to be sure your documentation matches. That's another thing. So sometimes the patients said the babies went back to the nursery, but then their face-to-face rounds showed me that the babies were in the room. Well, I need to know if this is a specific nurse that's kind of slipping that baby out to let that mom rest, but not truly documenting it in the right way. So those are definitely things that some kinks you want to work out before Baby Friendly comes to do their own site assessment. You want to match the EMR tool to the audit tools for easy data search. So I kind of took that tool and I took it to our IT department who developed our EMR, and they, like, for example, put a start and stop time in our admission assessment for the baby. I even put, we're adding a place for them to check where the bath was given, because that was an issue we were having. The C-section moms, some of the babies were going back and getting their bath, but it wasn't documented anywhere, so I assumed that that baby was with the mom the whole time. So you just really have to make sure that it matches exactly what they're saying, and that you can easily access that information so there's no confusion when baby friendly comes. For us, it was much easier to do all three, the 4 audit tool, 4 and 7, 9 and 10, and audit 6 all on the same patient. So I just made one packet and I do that all on the same patient. And you even, once you do it so many times, you'll get to the point where you can almost answer audit 6 based on what they told you from audit 5, 8, 9, and 10. And you'll get so used to those audit tools that you won't even have to look back sometimes at the questions. Keep a log of the audits. So if you're going to have more than one person doing the audits, I suggest making a notebook of some sort. We have a audit notebook on our postpartum hall where they write their J number or their the patient's medical number on there and the date and who did it. That way you aren't accidentally auditing the same person, especially if you're going to go back and make phone calls to complete the audits you may have missed. Wait until all the audits of the month are completed before tallying. I caught myself not remembering, had I already counted this one, or did I already tally this one up? So it was much easier for me to get in a quiet room and spread out, shut the door, and just sit there and tally and focus, because, like I said, even if you have a bunch of distractions or trying to do something else, you'll think, did I just tally that one up, or did I already count this one, or did I not count that one? So that would definitely be my advice as far as tallying them up, because they can get kind of confusing and all start running together. The next thing is acting on the audit results. So like people were talking about before, you've actually got to have a plan. So we share all our with all our audit results with our staff members. I highlight the ones that fell below 80%, but also it's very important to make sure you praise them on the ones that they improved on, even if they didn't meet the 80% yet. So for example, our room and in rate hit 80% in April, and then it was 78 this past month. So this was huge for us because we started at 50% when we started doing this. Brainstorm with your core team on how you can improve each thing. Simple reminders, whether it's via email or a unit meeting that the managers are having. Make sure just consistency. You know, you may have to tell them a million times that don't forget to teach feeding cues, but at some point it's going to click. Further staff training, so we're planning like a little skills fair, so to kind of keep everyone's skills up, because those 4-hour competencies and the 20-hour training can run together, and then if it's been a year since they've done it, you just have to keep them fresh and remember why we're doing this. One-on-one staff counseling if there's a trend noted with one particular staff member. So if you notice that one staff member is not documenting right, or whether it seems to be their patients that are always saying that they were taught to feed every 2 to 3 hours or 3 to 4 hours, make sure you kind of keep up with those type things to see if you need some one-on-one counseling. Our staff audit tools. So this was something we were wondering how we were going to accomplish, how were we going to audit every staff member or get everyone ready. So what we did is we made up like a little cheat sheet booklet and basically went down that audit tool word for word and wrote the question and the answer that they need to know, and everyone got a copy of it. Then we have a net learning resource, and basically it's just staff education, whether it be competencies hospital-wide or just updates on our EMR, whatever it is. We have this tool that people can put a question, some type of teaching, and actually have a quiz at the end that they can answer and to see how they did. So we actually took that audit tool and input it into our net learning, and you can actually see here how it looks. So every staff member, we assigned it to every staff member in labor and delivery, postpartum, and nursery. and they have to go and complete it. And we knew that there's going to be some asking your buddy or them doing it all together on a shift at one time, and we're okay with that because at the end of the day that means they're learning, they're looking up the answers, they're talking to each other and trying to figure out what their correct answer is. After they've completed it, we can actually get a printout of exactly their answers and what they said. So if at some point they say, and we added a couple of questions at the end of it. For example, we added, have you been oriented to the policy, infant feeding policy? And the answer is yes or no. And so those are simple questions that you can add. You can tailor it to however you need or whatever you want to make sure your staff knows, but this is also a quick way to assess your staff's knowledge. And so if y'all have some other type of format that your hospital may use to do your competencies, it's an idea to be able to upload the audit tool for the staff on there as well to be able to assess them. I also plan on getting this released again in about a year right before our on-site assessment, so it just stays fresh on everyone's mind and let it be an annual thing. The next step is just making sure the numbers of audits are done each month are consistent, and we consistently have the right amount, because you don't want your numbers to be, you want them to stay consistent. And if you have the same number of audits each month, then you can actually have a true picture of how well you're doing and where you're improving. And then our EMR, we definitely can tweak our EMR a little bit more, so we're gonna be working on that as well. And I think that's it.
Oh, I was muted. Thank you so much, Lindsay. That was great. I love all of the detail that you gave in there about the different, how you chose different people to conduct audits, the different types of audits, and how many you do. Yeah, that was wonderful. Thank you so much. So now we can take questions from whoever might have them. I don't see any questions in the chat. Paige, do you see questions in the chat that I am not seeing?
Yeah, I have a couple of questions that were sent, I think, directly to me. So I can
oh, great.
If you want to start with that. So from Cassandra
that'd be great.
Greenwood +4, she asked, how did each of your facilities implement Baby Friendly when the staff care for a large number of medical surgical patients? And if I read your question and you want to jump in and elaborate or like talk, go ahead.
This is Renee. And
let's see. Great.
Nice. You want to answer, Kirsten? Or?
Yes, thank you. Go for it, Renee. Okay. That would be wonderful for you to answer that.
The reason I jumped in is because that's really a big challenge for me. What we're going to do too is, like Lindsay said, we're going to do just some skills fairs and how to do some audits. I mean, check off some one-on-one with them when they're not with their patients. And I have found that the med-surg nurses that are assigned to us on a day when they're not assigned patients on the floor works much better because they're not distracted. They're just one-on-one with lactation or with a newborn nurse. So that just not having that extra burden of having a med-surg patient will help.
Great. And just for the sake of time, thank you so much, Renee, for answering that question. I'm interested to hear the next question. Paige, do you want to read the next one?
Yeah, so I have two more, and they may have been answered through the presentation. So I'll go ahead and read them anyway, so that if anyone wants more elaboration, they can get that. From Sabrina, she asked, how do you do your prenatal education without a prenatal clinic? And this was during Renee's presentation. So it may be directed towards what Renee experienced.
Yes, and we, like I said, I try to do more with the OB clinics. I try to get over there often as I can to work to give the managers some of our education materials, our packets. And if anyone wants to know what Jean Dunn from River Oaks also sends packets to her OB offices, so we'll be glad to send you kind of a list of what we send to the OB offices. And then we try to just kind of hit on if moms are pre-registered and coming here to the hospital for lab or x-rays or whatever they need to come in for, ultrasounds, we try to know ahead of time that they're coming in and meet with those moms individually too.
Wow, that's a lot of coordination. That's great, Renee. Thank you.
And Renee, while I have you here, Cassandra just asked, what is the nurse-patient ratio at your facility?
We have for lactation or just in general?
Maybe
probably in general.
In general, I honestly do not know for the other units. I know for lactation, we have 2 full-time lactation nurses and a PRN. So it's myself, another CLC, and then the other IBCLC works weekends. So we're blessed with a good lactation staff for 1,100 deliveries a year.
Yeah, I don't know, maybe Lindsay and Carmen, do you want to just say what your staffing ratio is? Just so we can get an idea.
This is Lindsay. I was going to say, we have our postpartum nurses on the OB hall. They usually take, the max is 6, but we really try not to let them get that high. Generally, it's about 5. But on busy days, the max that we allow one postpartum nurse to 6 OB. to 6 postpartum patients. But now we also have separate nursery staff taking care of the babies. So it's about the same as far as well baby goes.
And this is Carmen. It's the same for us as well as the separation with the postpartum patients. It's usually 1 to 5, 1 to 6, and then we also have a separate nursery as well.
Okay. Are any, well, it doesn't sound like, Renee, is your hospital doing couplet care, or are you doing?
No, we're still separated.
So it's all.
We have a med-surg postpartum unit that's combined, and then we have newborn NICU that's combined.
Great. Okay.
Yeah.
Awesome. Paige, do you have any other questions there that need to be read before we jump off? I know we're over time here, so I'm trying to not get too crazy.
Yeah, I'll try to ask this last one from Brittany,
Okay.
who asks, how can WIC staff help hospitals in this journey other than through prenatal counseling?
Ooh, have any of you three worked with your WIC staff very much as part of the baby-friendly process?
Hey, this is Carmen. We actually do have a pretty good relationship with our WIC coordinators, and we actually have a meeting scheduled tomorrow just so they can discuss with us again the benefits or some of the things that they're able to offer for the community, and again, once the patients are discharged, what services they offer to them as well.
Great. Lindsay or Renee, do you have anything different or unique that you guys do with WIC?
This is Renee.
I know our lactation has a good, really good working relationship with our WIC department, and our WIC department will come up here and hand deliver pumps for if a mom needs one from the WIC department. So I know they keep close relations, but other than that, I'm not real sure.
And this is Renee.
Okay,
we will refer to WIC. They don't. We're not set up so that they can come in and help with education, prenatal education right now. So, but we do refer to them, especially if we have a mom going home that needs extra help.
Great. Excellent. Well, thank you to all of our, I'm gonna wrap it up at this point, I think, just for the sake of time. Of course, if any of you have questions, please don't hesitate to call or email your CHAMPS coaches. I'd like to thank our presenters, Carmen, Renee, and Lindsay, again for all of the time and energy that they put into preparing their presentations and sharing all of that information with us. So thank you all so much for coming today. I hope you were able to pick up some tips and tricks, and we will catch you back in September. Again, as always, if you have questions, let your coaches know, and we're wishing you a lovely day and many smooth deliveries. We'll talk to you all later. Have a good day.
And bye.
Bye.
Thank you.